My name is Michael Betel, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. Today on our FLA Fireside Chat, we have three very special guests who are here to chat about the much needed, much anticipated, and very much appreciated AASLD practice guidance document for physicians in allied healthcare, enabling them to continue offering the very best of care for their NAFLD patients. The document is called AASLD Practice Guidance on the Clinical Assessment and Management of Non-Alcoholic Fatty Liver Disease. With us today, we have Dr. Diana Barb, Clinical Associate Professor in the Division of Endocrinology, Diabetes and Metabolism at the University of Florida in Gainesville, Florida. Dr. David Kleiner, who's a pathologist in Bethesda, Maryland, and with the Center of Cancer Research and National Cancer Institute. And Shadab Siddiqui is a hepatologist from Virginia Commonwealth University. And on behalf of all NAFLD patients and all the medical professionals that will definitely use and are already using this document, thank you for all that you've done to put this together. My first question for each of you is, what is the most important takeaway message from your perspective from the statement, and why is it the most important? Diana, you want to start?
Sure. Thank you, David, for the introduction. And, I'm very honored to be here and very honored to be part of this effort. This guidance document is we are very proud of, and it's along the lines that have been emerging lately with the American Gastroenterology Association, as well as the ACE guidelines that I was fortunate to also work with and participate in writing. So this is along the same lines, and it's essentially to increase awareness about fatty liver disease and especially metabolic disease, as I see it as the only endocrinologist in the group. And I should probably say that I'm slowly becoming here a gastroenterologist. I should give maybe a personal information. My sister is a hepatologist, and she, I keep telling her, I'm becoming a hepatologist more and more. And she says, well, you should, because fatty liver disease should be treated really in the endocrine setting. By the time these patients get to me as a hepatologist, and of course she sees patients with advanced liver disease, it's a little bit too late to intervene. So I think one of the message here, and perhaps the most important that I see, is to rely the importance of diagnosing fatty liver disease early on, and the message for the primary care and the endocrinologist should be to apply this guidance document to look for this disease, to diagnose it, and apply the guidance to move forward. As in the endocrine setting, we see a lot of patients with diabetes, and perhaps the most important impactful risk factor for NAFLD is diabetes. And why is it important? We know that when you have a non-alcoholic fatty liver disease, you also are at risk for about twofold, actually, increased risk of incident diabetes, as well as worse lipid profile and increasing cardiovascular disease. So it's important to start early on and diagnose this patient and relay the message that they may have NAFLD or NASH, and screen for clinically meaningful fibrosis, because we do have, I think, drugs nowadays that are available. They are not approved. There is actually no FDA-approved drugs for treating NAFLD. However, we have drugs available to treat obesity and diabetes that have an impact on cardiovascular disease and disease progression. So I think that would be, the main important message I would have to say, and I'm going to let others to come in, and happy to add some more.
And thank you for that. I have questions for you for sure. And Dr. Manal Abdelmalek, thank you for joining us as well. We're just talking about what was for each of us from our background, what is the most important takeaway from the document? And Dana was first. So David, do you want to go next and let us know what your thoughts are?
Sure. So I was responsible for the section on liver biopsy, and this is a guideline that's directed mainly towards primary practitioners. So it's a short section, because usually the biopsies are done once the patient is referred to a hepatologist, and then only if if needed. And I guess the message for me is that the role of the liver biopsy is changing because we have more non-invasive tests than we used to. But I think it still does have a role when you're getting conflicting information from your non-invasive tests, or when there's a significant alternative liver disease that's you either know is present, but you still need to evaluate for fatty liver disease, or if you're trying to rule out a second, the contribution of a second liver disease. The other thing that I would just point out to your audience is that there are new tools in pathology that are becoming more available to us and more accessible. There are a lot of AI tools that are being implemented in pathology now, and probably over the next 10, 15 years, we'll see some of those implemented in practice, and that will help the pathologists and it will help clinicians understand the value of what they're getting from the liver biopsy.
That's great. Thank you so much, David. Shadab? Oh, you're on mute.
Yes, yeah. Welcome to Zoom, I guess. So one of the more important things for me in the document is our approach in recommending screening. And sort of just to preface that, this is a disease that's very common. 1 in 3 Americans have it. And a significant portion of those patients will actually progress to more advanced disease. And in fact, liver cirrhosis from NASH is now is the leading cause of transplant in elderly patients in the United States, as well as women, and rapidly going to be overtaking all other causes in the near future. And part of this has to do with detection, as Diana was saying, the disease is detected too late. And so finally, we're taking a stand and saying that this is a disease that should be looked for actively. And if more importantly, we're looking for the more advanced disease phenotype. And if you have them, sure, we may not have readily available therapeutics that specifically treat NASH, but there may be a way of synergizing care with other specialists. There may be ways of screening patients, so patients who may be about on the verge of getting cirrhosis or have cirrhosis, just so that we can optimize their care, optimize screening, optimize collaborating with other providers that take care of this patient. And the goal is to actually improve outcomes. So we know what the end result of having this disease is in a significant number of patients. But can we, now that we are looking for it, now that we're actually seeking it out, can we actually change the natural history or the outcome of the disease in a positive way? So that to me was an important part of the guidelines.
And if we do that, then David won't need to do as much work on his side. Manal, what's I know it's going to be tough. 29 statements, and we spoke about this a week or so ago. So what's your key piece that you think should be taken away?
I think to complement what all my colleagues and co-authors have said, this document really brings us to empowering our clinicians to utilize tools which we didn't have 10, 20 years ago, and caring for this patient. Historically I've done far more biopsies in my former year than I do currently. And I utilize biopsies when the diagnosis is less certain, when I'm concerned about overlap or confounding of the diagnosis, or when my non-invasive tools leave me in an indeterminate range of discerning the presence or absence of advanced liver disease. So as Dr. Siddiqui and Dr. Kleiner pointed out, and Dr. Barb, we're really able now to utilize clinical predictors such as diabetes, family history, age, the tools such as our fib-borne elastography to tailor our approach to the diagnosis and stratify patients. So I suspect Dr. Kleiner is receiving less biopsies than he used to 15, 20 years ago, but we are able to utilize these tools and empower our colleagues in primary care and endocrinology and gastroenterology to figure out who they can not worry about versus who they really need to refer for more integrative care models.
Okay, that's great. It's interesting. So, and that's the beauty of having all of you on this paper, because we all have the same interest at the end of the day, and that's to identify patients as early as possible through the least invasive ways, if possible, and to make a difference in their lives. And so, I think you've all touched upon that as well. What would be most challenging, do you think, part of executing that? And as Dr. Siddiqui said, we have, I know the numbers have gone up. It used to be 1 in 4 of us have fatty liver disease. Now it's like 33% that we know of, and it's probably higher. I suspect our numbers, our estimates are probably still low. But so what would be the challenge in actually doing some of these things that we just talked about? I'll go back to Diana.
Yes, thank you, Mike. I think, the challenges, especially in primary care endocrinologists, when you have to deal with so many other problems that the patient has, is perhaps to maybe try to not forget and touch on this problem. So the way I think about it is, especially in patients with diabetes as well, this is, one of the metabolic complications that I need to screen for. And similarly to other tools that we have available, for example, in patients with osteoporosis, when we use a FRAC score, right, that we apply as a calculator to give us a screening tool. Similarly, what the guidance is recommended to use a NIT or non-invasive test like the FIB-4 example that we recommend here. It's a very simple test to apply that can be integrated, I think, in the electronic record, and hopefully spill out a recommendation for the primary care or endocrinologist to move forward. Since it's, I think the challenge is to find the time, and that, comprehensive visit that you have to do for your patient to apply this. So perhaps having this integrated in a medical record, as we do have it here, actually, it will help streamline or as a pop out on your screen that will help you move forward. And then from screening to diagnosis and then treatment, of course, there is multiple barriers, as we know. But I think perhaps that would be the first part that I found most challenging, to find the time and think about it.
And you're right. And physicians share with us, especially primary care, how busy they are every day. And so it's not top of mind yet, which we do have to get to. David, what are your thoughts? Where's the challenge coming from?
Well, so I'm on the back end of things. So, but what I see is just getting education down to primary level, so that they understand how to use these tests. The things that I see, I see sort of after the fact, right? But when I'm consulted, I get the record from the outside hospital or whatever, and the use of tests is inconsistent. People often have not screened for other liver diseases. When the biopsy is not being done by a hepatologist, things get missed. And so because the disease is so prevalent, it really does something needs to happen in that primary care office. And I think increasing awareness and also giving them some structure as far as, what to do first and when to refer and that kind of information, and just making sure that education penetrates widely throughout the primary care community is probably the greatest challenge. How do you reduce this practice?
Thank you for those thoughts. Shadab?
So I think one of the challenges that I foresee is we hope that we increase awareness of the disease among physicians, both primary care and specialists, but also patients. But the flip side of increasing awareness of a disease among providers, it sort of creates an increased demand on the healthcare system. So setting up infrastructure that's in place to then now have all the patients that are being screened through primary care, endocrinology clinic, gastroenterology clinics, how do they get to appropriate providers to take care of them? And I think I foresee that as a potential challenge in the future. Not to say that cannot be overcome, but we as a community have to be open to solving that problem.
I think, Manal?
You know, and being on the front end, and I suspect those that are clinicians can relate to this. I think the biggest barriers are time and resources. You know, it takes, even if it's a, you know, something as simple as a FIB-4 score that you could do at bedside, there still is an encumbrance on an allowance of explaining to a patient what this means. Oh, now there could be liver disease in the equation, in addition to, you know, looking at their eyes and their nerves and their kidney function, and now you're putting into the equation liver disease. So for every small element that we do in a clinical practice, while it seems small, it does have an additional encumbrance of time and resources, such that there are appropriate extenders to us who can extend that necessary, you know, dietary education or lifestyle modification, or take the time to explain that FibroScan that you just did. Primary care physicians are really, really strapped for time and sometimes resources. But there's also that element of education. It's all too often that I still hear from my patients, yeah, they told me I had a fatty liver, but I didn't need to worry about it. Or you know, my doctor's been following my liver enzymes for the past 10 years and there was nothing to be done about it. So that theme still resonates. And we have to debunk it. We have to debunk the fact that, yes, and while in a majority of patients, it may not be progressive, in certain cohorts of patients, it certainly is and does progress to cirrhosis. And we need to render more education appropriately.
Yeah, you've all also touched upon the fact that this is a very big issue globally, and it's going to take a lot of work. And the work that you have already done putting together the guidance document is definitely a great first step to try to coordinate some of the multidisciplinary care that we're clearly going to need too. And so that's another topic I'd love to talk with you again another time. We didn't have a lot of time today because I want to keep my promise to keep it short. So I thank you very much for those comments. We're going to share these with people, and I hope I can snag some more time with you so we can delve into different areas of the document, because it was all really, really great. Thank you so much for coming today.
Thank you.
Our pleasure.
Our pleasure, yes.
Bye-bye.
Bye.